Today we are going to discuss atrial septal defect. Now before we go to the atrial septal defects, we go through a little bit of the development of the atrial septum, because the atrial septal defects are of many types, not one simple defect. You see, during development there is a single atrium and then a septum grows. This is called septum primum. Grows downward and the lower portion is completed by the endocardial cushions. They grow upward and then they fuse. When they fuse, the defects appear in the septum to communicate between the two atria. Because if this septum is closed, there will be no communication between these two chambers. Now, then another septum grows on the right side. This is septum primum. This is septum secundum. And then there are a few more associations that vena cava may be attaching to this part of the atrium, superior vena cava, or they may be inferior vena cava. And then you've got sinuses, the aortic sinuses, out of which the coronary arteries they develop. So the atrial septal defect is a problem in the whole of this apparatus. If this septum primum fails to fuse here, this is called Ostium primum Asd. Since these endocardial cushions are also involved in the development of tricuspid valve, mitral valve, and interventricular septums. So the problem in these cushions, in which there is a hole left as ostium primum defect, there may be problem in the tricuspid valve, mitral valve, and the interventricular septum. So this may be associated with a tricuspid regurg or a mitral regurg, or there may be ventricular septal defect as well. So ostium primum may not be simple. It may be associated with these three defects. That there may be tricuspid regurgitation, there may be mitral valve regurgitation, or there may be ventricular septal defect. And now these are ostium secundum. This is the when there are defects in the ostium primum, these are called ostium secundum. Sometimes they fail to fuse. They are fused when close to the birth. If they fail to fuse, then this defect is left as ostium secundum. This is nearly in the center of the ostium. The ostium primum defect is in the lower part. This is almost in the middle, and then you've got two other defects which may be lying above and below. Now this passage, as you see, if this ostium primum is fused, now the blood flows through this passage from the right atrium to the left atrium. This is called foramen ovale. This closes at the time of birth, but if it may persist as persistent foramen ovale. And then you've got a small other type of defects. For example, if the vena cava, inferior or superior, fails to fuse or causes defect in the ostium, This is called Sinus Venosus Asd. And then sometimes the upper part of the septum fails to fuse with the coronary sinus, and the blood goes from the right atrium into the coronary sinus and then into the left atrium. So this is called coronary sinus. ASD. So now you got multiple type of ASDs. You got Ostium primum defect, that is the Ostium primum which fails to fuse with the endocardial cushions, and the defect is left. These endocardial cushions are also involved in the formation of tricuspid valve, mitral valve, and interventricular septum, upper part of the interventricular septum. So the Ostium primum defect may be associated with tricuspid valve defects, mitral valve defects, and interventricular septum defects. Mostly it is the mitral valve which is involved, tricuspid valve is sparingly involved. So the Ostium primum, then you've got Ostium secundum defect, that the perforation in the Ostium primum, they are called Ostium secundum, and they fail to fuse. This is called Ostium secundum defect. And during this period there is growth of a septum on the inside of the right atrium, and the blood flows across this channel into the left atrium. This is called foci vallis. Sometimes this foramen ovale, this foramen ovale fails to fuse, so we call it persistent foramen ovale defect. Then you've got sinus venosus ASD, when the inferior vena cava or superior vena cava cause problem in the interatrial septum. And sometimes there is a small defect in which there is a communication between the right atrium, the coronary sinus, and then into the left atrium. This defect is called coronary sinus ASD. So we've got different type of ASD, but these Ostium secundum defect and Ostium primum defect are the more common. Now what happens when there is an ASD? A child is born with an ASD. The pressures in the left side of heart are high, while the pressures on the right side are generally low. As the child takes a breath, the lungs expand, the pulmonary vascular resistance decreases, and there is decrease in the pressure against the right ventricle. So the right ventricle and right atrium are low pressure chambers, and the left atrium and left ventricle are high flow chambers. So what happens? The blood starts flowing across this defect into the right side. So the right atrial pressure rises, the blood flow across the tricuspid valve increases, so there is increase in the RV volume. The result is right ventricular pressure starts rising, and for this the right ventricular afterload, that is the pulmonary vascular resistance, also starts increasing. So this results in ultimate increase in the RV pressures. When RV pressure increases at a stage, the pressure in the RA and LA, they start equalizing, and then what we find is a shunt reversal. When the pressure in the RA goes above the LA, the blood will be starting shunting from right side to left side, and you see venous blood will be coming into the arterial side, and this may produce the appearance of cyanosis later in life. So this is what we see as a theoretical possibility. As the child grows, there is increase in the right-sided pressures. These pressures, they increase, they equalize in the left-sided pressure, and the shunt is reversed. This is shunt reversal is called Eisenmenger syndrome. But generally this does not happen. It has been observed only 15% of the patients show that there is shunt reversal. Why there is not shunt reversal? Because this lesion does not produce great stress on the cardiovascular system, and the symptoms are usually present after the age of 40 years. Till then the lesion is tolerated, and most of the time it is diagnosed on clinical examination done for some other reason. Now what happens as the pressure in this side rises with the growing age, the compliance of the left heart also starts increasing. That means the pressure in the left side also start increasing as the pressure in the right side is increasing. This increasing pressure in the right side, they prevent this shunt reversal. Got it? Normally what it should happen, that when there is a pressure in the right side, it is increasing. When it equalizes the left atrial pressure, this should start causing a reversing of the shunt. But this happens in a very small number of patients. Why doesn't this happen? That because on the left side, with the growing age, the compliance of the left side also starts decreasing. So it means the pressures in the right side are increasing, at the same time the pressure in the left side are increasing. They are preventing the shunt from reversing. So that's why this Eisenmenger syndrome is seen in less number of patients in cases of atrial septal defects. This defect is seen more often in other shunts like PDA or ventricular septal defect, but in atrial septal defect, for this reason, the shunt reversal is seen only in 15% of the patients. Now we see what are the clinical features of an ASD. Clinical features are basically three types. They're because of the heart failure, they're because of the increasing size of the atrium. You may have arrhythmias, like especially the atrial fibrillation, and then you've got paradoxical emboli. We discussed as the pressure on the right side keep on increasing, the right heart ultimately starts failing, and we have feature of right heart failure, and patient has exertional shortness of breath. Patient may have ankle edema. Patient may have abdominal distension and painful liver. There may be episodes of palpitation when the patient has atrial fibrillation, and some of the patient may present with paradoxical emboli, that is, patient may present with TIAs or strokes. So in a young patient who is less than 55 years, a TIA strokes should prompt you to examine for the presence of paradoxical emboli that are coming from the atria. Now, what is paradoxical emboli? What normally happens is, in a normal circulation, the emboli are formed on the left side, and they go through the aorta and lodge into distal circulation. Maybe it is brain, maybe it is peripheral arteries, maybe it is intestine, maybe it is kidneys, maybe it is in the eyes. The paradoxical emboli is that a DVT which is formed in the cable system goes into the right atrium and should go into the lungs through the pulmonary artery. It goes into the right atrium, goes into the right ventricle, and then it goes through the pulmonary artery into the lungs. But here what happens, that there is an embolus which is coming from the cable system, comes into the atrium, and because of the septal defects goes into the left side. And here it is fired through the aorta into the systemic circuit. So this is paradoxical embolism. So the patient may have paradoxical embolism. If a younger patient presents with strokes, one should look for the presence of the possibility of a paradoxical embolism. So it should be evaluated for the presence of atrial septal defect. Now, what are the findings on examination? Now we see what we find on examination. You see, the precordial examination reveals us that the apex is in normal place. There is left parasternal heave. That is because of RV hypertrophy, right ventricular hypertrophy, when there is a persistent elevated pressure in the pulmonary circuit against the right ventricle has to eject large amount of volumes. The right ventricle starts hypertrophying, and then you see a left parasternal lift here. You may feel a loud second heart sound. Second heart sound sometimes is so loud that it becomes palpable. When you auscultate, you may hear, number one, wide fixed splitting of second heart sound. The second heart sound is not only loud, this is wide, and the splitting is fixed. That means the splitting does not vary with respiration. Now, why this does not vary with respiration? When we see the normal physiology, with an intact interatrial septum, what happens during inspiration? There is increased venous return into the right atrium. During expiration, the aortic valve and the pulmonary valve, they close almost at the same time. A2 and P2, they're occurring at the same time. So in expiration, there is a single second heart sound. In inspiration, there is increased venous return into the right atrium. There is increased end diastolic volume of the right ventricle in RV. That means the ejection time of right ventricle is delayed. When the ejection time of right ventricle is delayed, the P2 is also delayed. So during inspiration, you hear a splitting of the second heart sound. In inspiration and expiration, you hear these as one sound. But during expiration, you hear a splitting. So this is called respiratory variation. What happens in ASD? During inspiration, the venous return increases. There is a pressure in the right atrium increases. This right atrial pressure would result in decreasing this shunt. This shunt decreases during inspiration. So the flow which is coming from the left side has decreased, although the flow from the pulmonary circuit, which is because of the inspiration, when there is negative intrathoracic pressure, the venous blood is sucked into the right side, is increased, but the blood which is coming from the left side through this shunt is decreased. This is what happens in inspiration. And now what happens in expiration? This blood flow in expiration, which is coming from the systemic circuit, decreases, while the blood flow through this shunt increases. So in RV, both in inspiration and expiration, the blood volumes remains nearly the same. So there is a fixed ejection time of the right ventricle. So the pulmonary component opens at the same time, both in inspiration and expiration. So you see, we see it again. In inspiration, there is increased amount of venous return in the right atrium, but the blood which is coming through this shunt is decreased because the high pressure in this chamber, because of this increased venous return, decreases this shunting. And during expiration, what happens? This flow decreases, the pressure in the RA decreases, therefore the shunt flowing through the left atrium to the right atrium increases. So in both phases of respiration, the blood volume in the right ventricle remains nearly the same, so therefore the ejection time of the right ventricle remains the same. So this V here, because of this, are splitting which does not vary with respiration. Then you may hear an ejection systolic murmur at the second and third intercostal space left side because of the high blood flow across the pulmonary valve. And then, as we discussed, that in a very large defect, there is a large amount of blood which is flowing across the tricuspid valve. When the shunt is large amount of blood is flowing across the tricuspid valve. So that will result in a high flow murmur. So you may have a diastolic rumble of tricuspid valve. And in Ostium primum defect, as we discussed, that there is a defect in the mitral valve leaflet. So you may have a mitral regurgitation and a hollow systolic murmur of MR. So this may be the physical findings on examination. And now we go to the investigations. The first simple test is ECG. What ECG may show us is RV hypertrophy. There may be right axis deviation. There may be complete or incomplete right bundle branch block. There may be P-wave inversions in leads 2, 3, and AVF. In cases of sinus venosus defect. So you may have these changes in the ECG. And then a chest X-ray will show us pulmonary plethora, there is increase in the size of right atrium and right ventricle. The aortic knuckle is attenuated or is atrophied. So this is what we see on chest X-ray. The definitive investigation, which is far more helping us, is the echocardiogram. We may go for transthoracic echo. That can tell us the size of the RA, size of the RV, the extent of hypertrophy, the flow of blood, the ejection fraction, the end diastolic volume. That all can be calculated in echo. It can also tell us about the interatrial septum. And if we inject the contrast, we can see the direction of shunt. For example, if you agitate a saline, small bubbles are formed in the saline. If you inject these salines, these bubbles, they act as a contrast medium for the echo. So you can see the movement of these bubbles across the defect and see what is the direction of the shunt. It is from the right to left or it is in the left to right. And this can also be done on pulse Doppler or color Doppler. Both of these can tell us the direction and the amount of shunting. In some patients, we may require transesophageal echo. Transesophageal echo may be especially useful in sinus venosus defect. Then we got recent imaging modalities like CT and MRI. They can very clearly define the anatomy of the atrial septal defect, and in case of Ostium secundum, they can also tell us that there are 1, 2 or more defects, and is there an appropriate rim of interatrial septum available in the Ostium secundum so that we can place a device across it to stop the blood from shunting. So these are useful investigation, and then you can go for catheter studies if required. Now, what's the treatment? Treatment, there is a rent in the interatrial septum. The treatment should be a repair of that rent. It can be surgical, it can be through the catheter. So it can be open surgery or it can be catheter. Now, when should it be treated? If the shunt is 1.5:1 or more than that, should be treated. You see, at time what happens that the shunt is high, but the patient has developed increased pulmonary pressures. If the pulmonary pressures are greater than 2/3 of systemic pressure, there are chances that our surgery might not be useful, might even fail, so it will not be very useful. So in some patients, what we see that if we temporarily occlude the defect, for example, this is a defect, and we place a balloon here, we temporarily obstruct this lesion and see if the cardiac output is maintained, it does not drop, then this is worth repairing this shunt. This is one study we do before we repair. And the second is, in some patients there is pulmonary vasoconstriction. If you give pulmonary vasodilators and the shunt decreases, that means these are the patients in which shunt surgery would be useful. So first thing is that we repair the shunt, and the second thing is the treatment of paradoxical emboli. Paradoxical emboli is especially seen in persistent foraminal. If this persistent foraminal has fluttering ASD with it, fluttering septum with it, there are more chances of having paradoxical emboli. And another reason for the emboli is, one is paradoxical emboli, the other one is the conventional emboli. The dilatation of the atrium in the atrial septal defect initiates atrial fibrillation. Atrial fibrillation is one reason for systemic thromboembolism. So we have to see whether the patient is having paradoxical emboli or atrial fibrillation. In any patient who is younger than 55 years, if there are TIAs or there are stroke, one should go for the workup of atrial septal defect. And out of this, we have to decide whether it is the paradoxical emboli or it's the atrial fibrillation. So atrial fibrillation is generally paroxysmal in the beginning. So you have to go for a long-term Holter monitoring. If you find atrial fibrillation, then you don't need to touch this persistent foraminal veil. If you don't find there is atrial fibrillation is not there, then if there are paradoxical emboli, then this ASD should be closed. Otherwise, the patient can be put on antiplatelets. Anticoagulation with warfarin or direct acting anticoagulants, not very superior to antiplatelets. So in patients we don't find the cause, we should go for repair of the atrial septal defect, and if you think this is because of the atrial fibrillation, the patient may be put on long-term antiplatelet therapies. So this is about ASD. In the next lecture, we are going to discuss about the VSD.